everyone. And before I start, so we're going to talk a little bit of parenteral nutrition in the newborn today, key concepts and complications. And as you know, it's very difficult to talk of this entire subject in a short time, but I'm just going to talk of some important things about PPN. We'll just see a few things about why do babies need PPN, what are the basic nutrients, how to start, how to deliver, how to monitor, and some do's and don'ts about PPN. Of course, later on we can have a lot of questions. So, you know, in India, you've seen so much of development and such rapid development in the last few years in intensive care. And today we have such high-tech units there's so many in every city. And the TPN somehow, in all these developments that occurred, we went to ventilation, different modes of ventilation, we went to nitric oxide, whatnot. TPN somehow always lagged behind. So I've been talking of TPN, and most of the talk of TPN still focus on feasibility. Kaise karna hai, kya nahi karna hai. But when ventilation, people have gone way ahead. Why we have lagged behind? Because most people felt that TPN is not required. Without ho jata hai uske bagair. People try to get away with enteral feeds. So maybe on 2cc2 or 10% exposed, theek hai. Long-term impact of nutrition is not realized by many people. And the immediate benefits of nutrition, no matter what you're suffering from, maybe RDS, maybe sepsis, maybe inside, you need your nutrition in the background for a better outcome. The other problem is TPN requires both pharmacy and pharma. In all countries abroad, TPN programs are run by pharmacists. Whereas our pharmacy curriculums in India do not have anything about TPN. And you don't have these people taking the mantle of TPN. So it comes on us. And you need a pharma because unless they get the right things for you, you can't do TPN. They'll get fancy ventilators, but they will not get the right multivitamin for you because their profit margins are not very good. And we have been talking to farmers for a long time, but they think the market is not good enough. So this is one of the reasons. And then in fear of complications, or anything you don't do well, you're going to have complications. Whether you ventilate or put a central line, if your complication will occur, if the techniques are not right. And people think, why already NICU care is so expensive, you are adding more money to this, more cost to this. So people think it is more costly to do TPN. So this is the reason why it lagged behind. So we started in 1986, and you can see a very young photograph of mine there. So in 1986, Professor Vidyasagar from Chicago sent a lady to us. Her name was Tina Hatsopoulos, and she came from Chicago. She was a pharmacist who used to make TPNs, and she spent a week with us. And in 1986, we started developing her interest in TPN because she actually stayed with us and taught us many things. At that time, when we started TPN, virtually everyone died. So when we had to start TPN, people used to come to me and beg of me, sir, 2 din roko, we'll wait, we'll try other things. Please don't start TPN. When TPN shuru kiya, obviously the child did not want to make it because we started TPN very late. And obviously the child was so catatonic and septic and in shock that TPN can't do anything at that time. But we kept on improving things. We kept on talking to industry. We kept on innovating. And we could come to a point now that we do around 8 to 10 TPNs every day in the ICU. We give it for up to 1 to 2 weeks. The entire process of TPN that you see today is not done by us at all. It is done by dedicated TPN nutritionists whom we created and trained to such an extent that they now completely look after that part, right from calculation to monitoring. We created a software in 1991 and kept on improving on it. And the software now integrates parenteral nutrition, and it now makes it error-proof. And those who want, I can tell you details about it later. We hold regular TPN training twice a year, 3 times a year at every national and state level. And these are 1 and 2 day workshops, which are quite practical. And we also made the national guideline in 2010 for TPN and revised them recently in 2020. The important point is that the sepsis and metabolic complications that we see with us are very minimal to none. I don't remember when we have discussed TPN-related sepsis or things like that in our unit, because those things are so rare and so uncommon because dedicated people are monitoring it. And that's why I changed the topic of today's talk with the permission of the organizers. This was supposed to be the title of the talk. I've changed it to Key Concepts and Prevention of Complications. Let us not talk of complications. Let us see how to avoid them. And everybody need not go through the learning curve. We have gone through it already. So people can learn directly how these complications can be avoided. So going back in history, TPN is not new. 1969, William Hyde, he's called the father of TPN globally. He's the one who came up with the definition that is provision of nutrients to the intravenous route And here, very simple, a person who cannot feed should not be fed or cannot be fed through the enteral route should be given TPN. What a simple definition. Now things have changed. It's an essential part of critical care, the standard of care in preterm and low birth weight babies. And most importantly in India now, it's a mandatory component of accreditation in all IIT, NNF, NEH, everything. And that is one of the reasons why TPN has picked up a lot in India, because now you have to do it, you can't do without. I went for accreditation inspection to Bangalore, and in the middle of the NICU, there was a laminar airflow system kept, which was still unopened, which was still packed. So in the accreditation criteria, it is there. So they said, this is it. So kal aaya hai. मैंने कहा इसलिए यूनिट के बीच में नहीं रखते, उसको रूम में कहीं अंदर शिफ्ट कर दो. But they had to buy it because they are applying for accreditation. So because of that reason, now in India, TPN is picking up a lot. So this is the NNF guidelines. Anyone who is doing level 2 and level 3 in ICU, anyone who deals with babies below 1500 grams is going to be needing TPN. They have to arrange space and for preparation and dispensing TPN. So why do preterms need TPN? At 28 weeks, your stores of fat are only 20% of the term gestation, and your glycogen is only 25%. Our reserves are very, very low. And then you are going to be challenged with a lot of disease, and you are going to need nutrition. Now, this parenteral nutrition is not a new concept to the fetus. This fetus was already on TPN in the womb. Because the placenta was providing glucose, it was giving protein at 3 to 4 grams per kg per day, and it was already giving lipids at 3 grams per kg per day. So when you start TPN to this baby, when the baby is born, the baby is easily metabolically able to adapt to it because he's already receiving all this while in the womb. If you don't do TPN, this is what happens, and we have babies like this everywhere. This baby was referred to us nil by mouth for 11 days. TPN started very late, very little enteral feed, no HMF. You can see what has happened to the growth. Length, head circumference, absolutely constant. And this EUGR is becoming a big global worry. And in spite of what we are doing, we are still getting EUGR. If you don't do what you're supposed to do, then your problems are going to be even more. For a long time, we thought that nutrition has to do only with growth. If you don't give good nutrition, you will not grow. After that, you give good nutrition, you start growing again. But it's only in this century people realize that neurocognition is related to nutrition. And that is why this new interest in nutrition in this century, because people know it's not growth alone. We are talking of neurocognition, and you must have heard about this yesterday. I think we have a talk on this nutrition and the brain in the afternoon today. Now, sometimes we should have a TPN monitor. We have so many monitors. You should have a monitor that gives you only the nutrition of that baby every day. Then you know which way you are going. And with all these fancy monitors, you should have one that only tells you about calorie, protein intake, and what is expected and what you are actually delivering. If that's the case on the rounds, then our babies will do better. This is a study called the Stephen study, which is a landmark study, and this is quoted in every TPN talk. This study shows that in the first week of life, we are not talking of the entire NICU stay, we are talking the first 7 days. Every extra gram of protein that you give is going to add 8 points to the MDI at 18 months, and every 10 extra calories will add 4 points to your MDI. So first week nutrition, small change, little bit of extra protein calories, better MDI at 18 months. And this is studies quoted very often because this shows that TPN is so important that, if the small babies, if you don't support them, you can lose out on points. So the first message to you is that these VLBW babies and preterms are prone to calorie protein deficits. Postnatal growth failure is quite common, and it is associated with neurodevelopmental outcome as well. Now, this you must have discussed yesterday, but the basic benchmark, something that has to be done, you have to prevent postnatal growth failure. And that is bare minimum that is expected. No baby in the NICU should be catabolic. That's your first aim. Then you move and say, okay, let us have some growth also. We want some growth in this baby. That would be desirable. And finally, when we talk of aggressive nutrition and replicating what the placental nutrition was, then you can achieve in utero growth. And that is what is ideal. When we were sort of maybe 15, 20 years ago, we were repeatedly taught, and the books also wrote that in utero growth is not possible. The placenta and the intrauterine womb environment is different, and after that, babies cannot grow at utero rates. But we don't believe that anymore because our babies do grow at this rate now. Now, I don't know the body composition, but the babies can be made to grow at a significantly good rate if you are very proactive and positive. So if you give 50 cals per kg and 2.5 gram per kg of protein, you can prevent catabolism. That's our first aim, 50 cals and 2.5. If you go to 70 to 80 cals per kg and 3 grams of protein, you will get a positive nitrogen balance. So this is your second aim. And if you really want babies to grow, then you can see from this slide on the left here, you can see the protein requirement is 4 gram per kg, especially these three groups, babies below 1200 grams and the energy between 110 to 135. But 4 gram per kg in babies below 1200 grams, that will give you proper optimal growth. So basics of TPN, you know, macronutrients and micronutrients. Macronutrients are carbohydrates, proteins, and fats. Micronutrients are calcium, phosphorus, trace elements, and vitamins. And the carbohydrates, nothing much to talk about, is exactly like the IV fluids that we give. So I will not be spending much time on it. You can give a GR of minimum 6, ideally 10 to 12. And you many times need hypertonic dextrose, but that's like the IV fluid. You can make a combination of 5, 10, and 50% dextrose. And this I will not delve into too much. You have to maintain normal glycemia. Protein is very vital, minimum 1.5, and ideally you can go up to 3.5 parenterally. Use standard neonatal amino acid solutions. If I've written one name, but there are many that are coming into the market. We have a recent one now that is locally made. And these solutions have a high osmolarity. The reason I'm writing that is I recently realized a few units are directly infusing amino vein into the baby. But that is not to be done. It's an osmolarity of 1200. So it's written there, not for direct infusion. People don't know. They just hang it like a IV fluid and give it to a peripheral vein, which is not allowed. So the amino acid is part of the entire combination of dextrose electrolytes. You cannot infuse it like lipids in isolation. So that's just particular writing about the osmolarity. When you talk of TPN in many meetings, people say, "हम TPN करते हैं, but lipids नहीं देते हम." That's a common thing that people say. Then I say it is not TPN. If you're not giving lipids, it cannot be called total parenteral nutrition. It is just parenteral nutrition. People are scared of lipids for some reason. In fact, they are safer than the other components. They're isoosmolar, and they are like the chylomicrons, and they're hydrolyzed to free fatty acids. So we use this SMOF 20%. It's a combination of soybean, NCT, olive oil, and fish oil. And this has a lot of immunomodulatory properties. So this reduces cholestasis, it's better tolerated, and it also will reduce the chances of sepsis. So this is the product that we are currently using. Very good source of energy, is a part and parcel of TPN, 2 calories per ml, and an important calorie source. So this is something that's asked in the exam very often. And in the last exam, it was asked, all candidates got a 0 on this. One of the OSCEs. So nobody could get a single mark for this. I don't know why. It's a very simple thing. This calorie nitrogen ratio ensures that you are giving adequate calories for the amount of proteins that you are providing the child. So it just balances out your calories and proteins. Don't go into the formula. You can see the numerator is non-protein calories, the denominator is proteins. So this calorie nitrogen ratio has to be between 150 and 250. So that ensures that you are giving sufficient calories, and this prevents metabolic complications like acidosis and azotemia in the child. Nothing much to talk about calcium. It's the same calcium gluconate that all of us use, and that's an important part of TPN. It is started on the first day of life in all babies. Phosphates, erratically available in India, but again an important part of TPN because of metabolic bone disease that you have heard yesterday. So phosphorus should be added to parenteral nutrition whenever it is available. And magnesium is the same that we use, so I will not be going into details of that. Vitamins, we need proper pediatric multivitamin solutions, but unfortunately we don't have it and no one is willing to get them for us. We are using the same adult MDI 0.5 ml per kilo. It is recommended from the first day. Vitamin K is not there in adult MDI, so we give vitamin K weekly. And it contains vitamin A, which can give you some benefits against chronic lung disease. Whenever there are vitamins in the TPN, one has to cover the infusion sets with foil to prevent exposure to light and prevent peroxidation. Coming to trace elements, again, trace elements required, especially if you're giving TPN for a longer time. And zinc is something that is needed from the first day. And now we have standard Indian brands which give you reasonable amount of trace elements. So this is just one of the names, but you have other trace elements also given, especially if you're going to give TPN for a longer time. Let us go to some more practical aspects now. How much nutrients, what is TPN? And I will show this very interesting study. But this slide shows you so many colored dots. And there are 10 different studies that have studied amino acids infusions on day 1. So each study has a different color, and the size of that block indicates how many studies patients were enrolled in that. If you can see on the y-axis is nitrogen retention, and on the x-axis is the dose of protein. You can see it from here that only when this protein exceeds 1 gram that you get this positive nitrogen balance here. If you give anything less than that, these studies all show negative nitrogen balance and protein intake, which is less than 1. So this indicates that if you want a positive nitrogen balance, you have to start proteins on day 1, and you have to start with a minimum dose of 1 gram per kg, ideally even more, but minimum 1 gram per kg on day 1. That's for amino acids. And studies have shown that early parenteral nutrition is very safe, does not increase mortality and morbidity, and it does show benefits in short-term growth. So the second message would be that you need your amino acids on day 1, and anything which is less than 1 gram per kg is going to push you into a catabolic state. Though we spoke on the short-term outcomes, there have been studies that show that if you're given amino acids early, you are going to get better head circumference. Studies have shown lesser BPD. Studies have shown better IQs. So there seems to be a much wider role for protein than just causing growth in the particular child. Again, lipids also have to be started earlier. Most people start lipids late. So you have to give lipids because they're going to give you LC-PUFA, important for your brain, important for your eyes and your ears. And they are going to prevent catabolism, and they're going to help you to maintain your calorie nitrogen ratio. So again, start lipids on the first day. At least 30% should be calories from lipids. Dose to 3 to 3.5 gram per kg. Infuse over 18 to 24 hours. And whenever the babies are very small and the doses of lipids are high, you need to monitor the triglycerides to keep them below 200. So this slide shows you that lipids are graded up 1.5, 2, 2.5, and 3. But this grading up may not be required. You can directly start also with 2 grams. Next day, you can make it 3. So you don't have to necessarily follow this grading up pattern. And when people talk of aggressive nutrition, they start with 3 grams of proteins and 3 grams of lipids on the first day. And many units across the world practice this aggressive parenteral nutrition. We are not doing it. We start proteins at 2 and lipids at 1, and then grade it up next day. But many units do practice aggressive nutrition. So again, a lot of data to show that early lipids are safe. So don't be afraid of lipids. Whenever you do TPN, use lipids and use them also from the first day. So let's see someone is starting a TPN program or improving their existing program. Do you have everything? How do I calculate? Will I need some equipment? Will there be complications? Is it expensive? Are there any training opportunities? First thing to remember, start TPN once the baby is a little stable. If you're struggling with shock, you're struggling with PPH and RDS, baby is very sick, and you're making frequent changes to your inotropes, just wait a little, because TPN needs some stability. Because you can't keep on changing your TPNs all the time. You have to be metabolically stable also. Hemodynamics stable, electrolyte balance maintained, glucose requirement you are aware of, sepsis is controlled, baby doesn't have coagulopathy. So wait a little till your baby is a little stable. Maybe you can wait for a day or half a day. If you see these requirements for TPN, there is nothing in it that is very different from what you already had. I would only say laminar flow system is what you need to buy, and maybe you need a room for your TPN to prepare your TPN. But all the other things, your refrigerator, glucometers, and all is something that you already have. There's nothing specially to be done. I think this is the most important part, and there I think we succeeded a lot, because we don't have these pharmacies. I put question marks there, but you can create nutritionists. In every city, there are nutrition colleges, and there's graduates in nutrition who have done MSc and BSc. Now, those people who graduate from there go into the gyms, they work with diabetologists, and they just do some diet counseling. You can pick them up. These are the girls who can be changed into lactation consultants, TPN nutritionists, because they have core knowledge of science and core nutrition. But you can develop their careers And you can create these cadres because many hospitals are going to leave them. And we do that in Pune. We train many young girls and they get jobs in good hospitals and pretty good salaries. So we have to create TPN nutritionists. You have to talk to the pharmacist, but I think finally you need to create people. But irrespective of who is running your TPN, all the other people in the unit must know about it, the basics of it. So all resident nurses must have basic knowledge of TPN. So identify the baby, calculate the needs, prepare the TPN, put it up and monitor daily. So this is the software I was talking about. And our TPN nutritionists are present on the rounds. They know the clinical condition of the baby. So if we say that the baby is having renal impairment, they immediately take it down in the notes. They know that, well, my protein cannot be increased too much. So they listen to the clinical condition, which is most important. And they will ask questions on the round. So the TPN planning is done on the round itself. Now, this particular software makes it very sure that you are not going to make any error. Suppose I have to write the dose of magnesium and I forget what milliequal is becquerel. I don't have to worry too much. There's a help there, and if you put a wrong value, the software doesn't give you a printout or doesn't calculate it. Say this value is wrong. Suppose you miss a decimal point in the potassium. So I will not allow you that potassium. You did potassium of 10. You'll say no, it's not possible. So this is what it helps, and it factors in all the market products. So you don't have to remember isme ye kitna hai, usme wo kitna. So you choose the market product, it will pick up exactly. If you say central line, it puts heparin automatically. So a lot of things are done and it becomes more error proof. And now because it's cloud based, if people can just run it on their mobiles, you don't have to really have anything else for it. So this is one of the screenshots of that. You can see the scroll bars here. They just go up and down when you calculate. So you don't have to put in the values. Just use those scroll bars and you calculate. And you also have an interface for enteral nutrition. So when you calculate, it gives you so much calories enterally, so much parenteral. So you get a complete summary of both. And it stores all of this data for you on a daily basis. So later on, after 10 years, you want to do a long-term outcome study, you know exactly what you gave on what day. Because everything is, it becomes a powerful research tool as well. And most important, plots the growth chart automatically. So when you plot a growth chart, you see what you are giving automatically, how it's going. So when you drive your car, you push your accelerator, you see it on a speedometer, what speed your car is going. And you can change the accelerator depending on what speed you want. So this particular interface on the round tells you what you are giving and what you are getting. So if you're doing well, fine. If you're not doing well, press the accelerator a little more. So this actually helps us to push growth. And because of this software, we've been able to make babies grow better. So this is on the round. You can see this TPN nutrition is there. She has this iPad tablet in her hand and she'll do calculations on a day-to-day basis right on the round. So when she puts height, weight, head circumference, you get the growth chart straight away in front of you. And this is how things work, and it become a part and parcel of our LSU rounds. How to prepare TPN? Laminar airflow system. Many people say we do TPN, but we don't have laminar. But that's not a good thing to do. I think if you want to do TPN, buy a laminar. It's not that costly at all. Don't cut corners in some things. And laminar flow is one thing that it's not very costly. A hospital may already be having it, and you can buy it. The cost is not prohibitive. You get much smaller models than these, which are even 40 and 50,000. So you don't have to spend more than ₹1 lakh. You can buy a smaller system also for yourself, but please use a laminar flow. All of us do this manual compounding and make TPN, but there will be standard PN solutions available in India very soon. And these solutions, once you get them, they will be on the shelf, like your Isolite P. You just be picking it from the shelf and putting it on the baby. And then you will not have to do the manual compounding that we are currently doing. So we are in the process of talking to many people to make the standard PN solutions. Just take it from the shelf and put it. You don't need a laminar flow. You don't need to do anything unless a particular baby has very different requirements where you have to calculate specifically. In infusions, the amino acid, dextrose, electrolytes, trace elements, and heparin are given in one infusion, and the lipids and vitamins are given together. They're connected by Y connector, or sometimes they can be infused separately also. Some people do it separately. Peripheral access is fine for short-term TPN if you have a problem with the central line, but if you have hypertonic solutions, if you're going to get TPN for a longer time, then a PICC is always better. And most of our patients will get TPN through PICC. Maybe we start off with the umbilical line, so the baby is very small and sick, and later on we shift to the PICC. This is a textbook list of complications of TPN. Dextrose-related, protein-related, cholestasis, this deficiency, aluminum toxicity, and whatnot. There's a huge list of complications of TPN that you see in the textbooks. But you just classify them as related to infusion, infection, metabolic, and nutrient related. So when you get this extravasation injury, this is not TPN, this is a poor care. This can happen with your dextrose also. This can happen with your inotropes also. So this doesn't come under TPN. This comes under poor quality of care in your ICU or poor monitoring. So this I don't put under TPN complication. So just see that your overall care and standards of sepsis have to be very good. Just a few words about parenteral nutrition associated liver disease. Occurs usually on long-term TPN. Risk factors are prematurity, SGA, NEC, sepsis, prolonged NBM, abdominal surgery, and a nutrient imbalance in PN. You heard me talk about this calorie-nitrogen ratio. So if your calorie-nitrogen ratio is not right, if you have trace element deficiency, all those things contribute to cholestasis, and it can lead to end-stage liver disease. It is not necessarily reversible. You can land up in serious trouble with the liver. So always, though we are talking on TPN, you must see whether you can give some feeds enterally. That reduces your chances of liver disease, early weaning of TPN, cycling the TPN, reducing the dose of lipids, maintain calorie-nitrogen ratio, use the newer lipids which decrease cholestasis, use fat-soluble vitamins by supplements in these babies, and some babies may need choleretics also. So TPN-induced liver disease, long-term TPN, and prolonged NBM and sepsis. This puts the baby into trouble. So try to avoid these factors that lead to liver disease. So let us talk of few 5 or 6 important prevention points. One, laminar airflow system is a must. I don't think it's optional. Please use that for preparing TPN as well as other fluids. Aseptic technique in preparation as well as setting up. When you set up TPN on the patient, see that it is done with proper scrubbing. It cannot be done like routine IV. So when you recite it, unfortunately, you have to scrub again. So it is a very tedious thing, but one has to do that. The lipid sets and lipid bottle has to be changed every 24 hours. Whereas the other infusion, the hang time can be 48 hours. And there is a study from India, only from Bangalore, that shows that up to 48 hours hang time is fine in India. The solutions don't get contaminated. But you have to remember, you have to change the IV set also. Follow the monitoring protocol, and we'll just discuss that. And do not break into TPN lines. TPN line is a TPN line. Don't try to push antibiotics and caffeine and other things to the TPN line. The minute you break that TPN line for other infusions, you'll land up in trouble. Keep a dedicated line, change it only 24 hours, so infection rates will go down. We should see this exhaustive table on monitoring. See it carefully. The last column shows that most of these things that you monitor, electrolytes, LFTs, triglycerides, most of them are generally weekly. We are not doing them each and every day. So when you are doing your other samples on the baby, you can add these things also, which are part and parcel of TPN monitoring. So we don't do an exhaustive blood sampling. If you're doing TPN in the right way, then your monitoring schedule can be curtailed a little. Yes, TPN is costly. These are taken for a single patient. So the solutions, the disposables, biochemical monitoring, compounding, around 3,000 rupees a day. So it's not less. It is expensive, but as you compare to other NICU costs, this is okay. This is a capital cost that you require. And this was single patient use. Now I told you we have around 8 to 10 babies on TPN at a time. The solutions get shared, the cost gets shared. So for our patients, not 3,000, it will be less than half of that. The disposables, my monitoring and compounding will be there, but this cost will be literally 1/4 because the solutions are being shared between patients. The liquid bottle will be shared between 10 people. So you can share solutions, use modest doses, prevent complications. Complications increase the cost. And reuse of nutrient solutions. So Indian Jugaad. The bottle says single use only. But there's so many things in life that we use that it's written single use, but we do use it again. This applies not to the lipid. Once the lipid bottle is broken into, it is packed under nitrogen. So once you puncture the lipid bottle, that has to be finished or thrown away. Amino acid bottle, you may, I'm not saying you must, you may use it again. But the lipid bottle cannot be reused again because it's packed under nitrogen. So please remember that. So to conclude my talk, we saw that parenteral nutrition is a part and parcel of neonatology and NICU care. You have to use it to optimize postnatal growth. It also affects neurocognition. Still underutilized as compared to other programs in NICU, but is an important facility for level 2 and level 3 units. Preterm low birth weight NEC surgical units are the main candidates for TPN. You must and prevent catabolic state, but you must ensure optimal growth. You need to prepare your team, get the right products, create the facilities. Complications are there, but you can keep them very minimum by training people and adhering to a good discipline. And innovations will help us curtail the cost. And the master of innovation is sitting in the audience in front of us, Dr. Girish Gupta. I'm sure he'll rack his brain a little more to see what we can do to save more money and then give good clean TPN. So these are the NNF practice guidelines. Those who want to have more details of this, you can go to the NNF website. And this is the detailed adaptation of TPN for the Indian situation, and they'll be revised in 2020. You can get it from the NNF website. Thank you very much.